Yes,
continue.
yes, please. Yes, please.
Stop.
Ma'am, we are on live, ma'am, and we are starting the session, ma'am. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is menopause management. I welcome all the participants. I request them to post their queries in the chat box so that I can read out it for you at the end of this session. So now it's time to introduce our invited speaker for the day, Dr. Neelam, ma'am. Madam has done her MBBS, MD, OG, and DGO, FI, COG. Madam is currently the senior consultant and medical director at Santati Fertility Clinic and ERT Center, Arvind Hospital, Bihar. Madam was the past treasurer of Patna Menopause Society.
No, I'm still.
Still, ma'am. Oh, sorry,
Yeah.
ma'am. Madam is the treasurer and joint secretary of Indian Fertility Society, Bihar chapter. And Madam has associated with this Patna OG Society and various posts, like Madam was the office bearer, past president of Patna Society, then chairman of various committees of OG Society, chairman of Endometriosis Committee. Madam has attended various international and national conferences as delegate and faculty, and Madam has also presented various papers. Madam has contributed chapters in books on critical care and many patient awareness books in Hindi and English as well. So Madam's special interest is high-risk pregnancy, safe motherhood, and population stabilization. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for further proceedings, ma'am.
Thank you, Dr. Stalin. I think I can share my screen now.
Yes, ma'am.
Yeah, can you see it?
Yes, ma'am.
Yes, ma'am. Visible.
So thank you so much for your kind introduction and good evening, friends. My topic of today is menopause management. And before starting it, I would like to thank Shield Pharmaceuticals for giving me this opportunity to speak before you on such a good subject. As we all know that menopause is a normal natural event which defined as the final menstrual period confirmed after 1 year of no menstrual bleeding. That is, it is a diagnosis in retrospect. So we can't say this is the menopause until and unless 1 year has passed of the final menstrual period. And menopause represents the permanent cessation of menses resulting from loss of ovarian follicular function, and it is usually due to aging. And owing to the declining estrogen and progesterone production by the ovaries, the menstruation stops and we reach menopause. What happened? Yeah. So let's see the prevalence of menopause in India. Globally, according to Hill 1995, the number of postmenopausal women in world will rise from 4.6 billions, 4.6 millions to 1.2 billion by 2030. And most of the increase in number will occur in developing countries. In India, according to 2016 census, there were about 120 million women aged 45 years and above, and this number is expected to increase to 401 million in 2026. So you can see what a huge population is going to stay in menopause period, and that will bring about more since the longevity has increased, since the aging is increasing, and since the aging is increasing in the post-reproductive phase. So there will be more chronic diseases in this period, and we have to gear up for this. So in Indian population of 1.3 billions, around 48.19% women are women. And of those 48.9%, 72% stay in rural area and 28% in urban area. So around 11% of women population are aged between 40 to 60 years. And that comes to a good number. So there is a huge scope for perimenopausal, postmenopausal, and menopausal clinics as well as doctors to give suggestions so that these women can lead uh, a healthy postmenopausal can progress to a healthy period in peri and postmenopause stage, and they should not get succumbed to the diseases which are there. If it I mean if it is managed in a better way and people take the advice, then there it will be a healthy geriatrics. So there are three stages of menopause: perimenopause, menopause as such, and postmenopause. Perimenopause is the time in a woman's life when hormone levels begin to decline, and this is and actually menses is a surrogate marker. So there is less regular periods as well as maybe hot flashes and night sweats, and these are the most common symptoms of this phase. Whereas in menopause, this is the period in women's life typical between 45 to 50 years of age when menstrual period stops occurring, and by the Indian Menopause Society it is 46 years average. And postmenopause is, and but this menopause you cannot predict. I mean, you cannot say until you have passed 1 year of your last menstrual, your final menstrual period, as it is called. So, postmenopause is a woman considered to be postmenopausal once she had gone 1 full year without a period. So, a menopause can be natural as well as induced. The natural menopause is diagnosis established when menstruation stops for 12 months in the absence of an organic or a pathological cause. It usually occurs at 45 to 50 years. If it occurs before the age of 40 years, it is referred to premature menopause. Induced menopause may be surgical when bilateral oophorectomy has been done, or radiological after irradiation of the ovaries, and so the ovaries stop functioning, or maybe due to chemotherapy after exposure to chemotherapy during treatment of malignant diseases of various organs. There is a strong staging system in menopausal terminology, which says that this has divided the period into plus and plus 2 and minus 2, plus side and minus side. Minus side is the period which is before final menstrual period. So there are many markers which we can see before it. So just before that, menopause is the period of -1 and -2. It is not actually the year that it will be 1 year, 2 year. It is not. That is the stage, and that depends also on the hormonal increase in the FSH. So the menopausal transition period is just before this, and in that there is in -2. This is variable when the cycle length starts varying. That is more than 7 days different from normal, that it becomes prolonged now. And when 2 or more skipped cycles are there and the interval of amenorrhea increases, that is more than 60 days, then she is in -1. Usually in this stage, the FSH rises and it has reached to, it gradually increases, and AMH starts decreasing. It is quite low in this period. Before that, there is a reproductive period in which the menstrual cycle can be variable but regular, and this is the usually the FSH is normal. But in the later phase of the that is the -3, the FSH starts increasing, and when the FSH level goes up to 40 milliunits, then you have reached the menopause. Then it is no going back, and this is the phase after the final menstrual period. 1 year, we call this is the postmenopausal period, and then it is +2, and there is no menstruation as such. So the staging system, it is a staging system of physiological event. It is to improve comparability of the strategies and facilitate clinical decision making. In 1997, Bahram and Kalseria of India, he published a simple clinical method of staging of menopause to understand, and Straw took it up there in 2001, And it, by Strauss classification, is aimed to classify the woman's life in 3 phases: reproductive, menopause transition, and postmenopause. So the serum hormone levels at menopause: circulating estrogens decline, ratio of estrogen to androgen, that also declines, sex hormone binding globulin secretion also declines, but there is increase in peripheral aromatization of DHEA to estrone, and there is no significant change in testosterone level. So when the estrogen starts declining, it manifests various health risks over time, like from the period of after 45, when the estrogen starts declining, then comes the, first of all comes the hot flashes, which a woman experiences, that she has a sudden feeling of hot in the upper body, especially in the face and face, neck, upper half of the body, and there is very warm feeling, and then it goes off on its own. I mean, after a few minutes, it goes off on its own. Then there is, after some time, when the estrogen decreases further, there is moodiness. You feel irritated, you don't feel good about it, and sleep may be disturbed, or maybe there may be some acute cognitive changes also, that suddenly you have started feeling forgetfulness, and suddenly you start thinking about, okay, I can't you remember the name of the person, what is it? Well, these are all due to that estrogen, lack of estrogen. Then comes the urogenital symptoms and skin changes. These are very important, because after hot flashes, this is the thing which bothers most in women in their perimenopause and postmenopausal age. So urogenital symptoms are more frequent, and skin changes also started occurring, and wrinkles and all come into play quite now, due to decrease in the estrogen. Then is the cardiovascular disease, which can come to the forefront a little later, at the 55, because if there is something, then gradually the decreasing estrogen takes care of it, but as it keeps on falling, so the cardiovascular diseases manifest themselves, and they come to the forefront. Then comes osteoporosis, that is the major one, that is the silent killer. It is called that the bones become just osteoporotic. I mean, the bones which were like peda and very crisp and compact, now they become batasha. Batasha, which just if you press it, it will crack. So it becomes, osteoporosis sets in, and it is a silent killer. It is an epidemic. You just have to beware of it. And then comes cognitive decline, that is after 65. If you don't keep your mental functions agile, and don't keep on doing things using your brain, then it is going to decline, and it is going to have cognitive decline will be there, and you will lose gradually. Alzheimer's may set in. So you have to use your brain, keep using your brain in one function or other. This is a slide we're showing Cooperman index. The Cooperman index is a combination of self-reporting and physician's rating, and this was of all the discomforting symptoms. And so there is it gives a numerical conversion index and to all the menopausal symptoms, so that their treatment and follow-up becomes easy. In which, of course, all the symptoms like vaginal dryness, hot flashes and night sweats, paresthesia, insomnia, nervousness, melancholia, dizziness, fatigue, arthritic pain, formication, palpitation, headache, all are there, and they are given a number so that their follow-up is easy. Now, let's see what are the menopausal symptoms and signs. The classical symptoms are change in menstrual cycle pattern in the beginning. And second is, most common is vasomotor symptoms. That includes night sweats and flashes, hot flashes. The other most common is vulvovaginal symptoms, dyspareunia and urogenital syndrome. Other symptoms which sometimes associated with menopause are sleep disturbance beside night sweating, cognitive concerns. It is not solely due to menopause, but due to decline, due to aging also, and less active, brain being less active. Cognitive concerns, memory and concentration. Psychological symptoms such as depression, anxiety, moodiness, because at this age usually it is emptiness syndrome, nest syndrome is also there, and children have grown up and gone out of the home to lead their own life. So that also hampers the mood and makes a woman depressed. Talking a bit about vasomotor symptoms, this is recurrent transient episodes of flushing accompanied by a sensation of warmth to intense heat on the upper body and face. As many as 75% of perimenopausal women in the US have hot flashes. This is the most common symptom in the menopause group. And this is triggered by small increase in core body temperature acting within a reduced thermoneutral zone. And this is very frequent. Even if you think something, your emotions can also bring about this hot flashes. Treatment is based on symptom severity and a woman's risk and personal attitudes about menopause and medication. It may go away on its own. Many women don't find it much bothering, and they don't complain, or even they don't complain of it, don't seek treatment also, and it can go off on its own. And it is also about your personal attitude about menopause and medication. So next is abnormal uterine bleeding. Abnormal uterine bleeding is excessive or erratic bleeding, and in this period there may be heavy menstrual bleeding, average blood loss more than 80 milliliter, and especially with clots. So if the menstrual bleeding is lasting more than 7 days, or it is more than 2 days or equal to 2 days longer than the usual pattern, then it is abnormal uterine bleeding. And if interval is also less, that is less than 21 days from the onset of one menstrual period to the onset of the next one, then it is also called abnormal uterine bleeding. Or any spotting or bleeding between periods, or even bleeding after sexual intercourse, has to be reported and counted in abnormal uterine bleeding, and it should be looked into. Vaginal atrophy, this is one of the major concerns, because the vaginal epithelium, which is multi-layered, as you can see in the slide on the left panel, which is multi-layered with the effect of estrogen. Now, as estrogen is waning, so it becomes, the layers become less, and it is thinned out. So it is low estrogen postmenopausal state. Urinary symptoms, this is one of the most common ones, and we call it genitourinary syndrome. This is common in midlife women, but no link to menopause-related estrogen loss has been identified. But it gets surely better with estrogen use. Over 50% of women of age more than 50 can land in urinary incontinence, and they also report symptoms of overactive bladder. Mild incontinence in early perimenopause tends to decline in the first 5 years after menopause. Weight loss for overweight women is effective, as is Kegel's exercise, that can cure more than 50% of cases of stress incontinence when performed regularly. And several medications are approved for overactive bladder syndrome. Sexual issues are also, and this should be specifically asked to them, because patients don't vouch for it, and this also increases with aging. And there is distressing sexual complaints peak around midlife, that is 45 to 64, and are lowest from age 65 onwards, naturally when the frequency of sex gets very less. The decreased estrogen causes a decline in vaginal lubrication and elasticity, and decreased testosterone may contribute to a decline in sexual desire and sensation. So an active sex life, together with lubricants and moisturizer and local vaginal estrogen, help to maintain a good vaginal health. Next comes atrophic vaginitis. Atrophic vaginitis is also called vaginal atrophy, and it is a chronic progressive condition which occurs mainly in postmenopausal women and is characterized by pale, thinning, shrunken, and atrophic vaginal epithelium, as it was shown in that picture. In addition to vagina, the atrophic changes also affects the urinary tract because of their common embryological origin. That's why when we apply estrogen locally, it helps in the recurrent urinary tract infection also. The condition develops slowly and it takes 5 to 10 years after menopause to manifest. And atrophic vaginitis affects 50 to 60% of postmenopausal women, but only 25% seek medical advice, and it is usually neglected because they don't know also. A combined approach is mandatory to reach a correct diagnosis of atrophic vaginitis, and this approach consists of proper history taking with special emphasis on any contact irritants such as local perfumes or deodorants or lubricants, because usually women, they forget to tell in the history that they are using some perfume or deodorant or special soap, or washing the vaginal area and vulva with Dettol water. That is very common in our part. For any problem, they will start washing with Dettol water and forget to tell this. Second is physical examination, and third is laboratory testing. So be careful to avoid the routine diagnosis of atrophic vaginitis in postmenopausal women with urogenital complaints. So urine culture and sensitivity is a must to know whether she is suffering from UTI, rather than just putting a diagnosis of atrophic vaginitis. Exclude other causes of vaginal infection such as bacterial vaginosis, candidiasis, or trichomoniasis. So a detailed history of recurrency of urine, dysuria, nocturia, hematuria, and incontinence. If there is any discharge, whether it is has any odor, whether it is thick or thin, this should be asked. A history of dyspareunia or sexual contact is a must, which may be followed by bleeding after intercourse, and vaginal soreness and itching also should be asked for. Physical examination is very important, but it is a little painful. So vaginal examination should be performed using a small lubricated speculum to avoid injury or bleeding from the atrophic vaginal tissue, or to minimize discomfort to the patient. And the examination reveals stenotic introitus, width is less than 2 fingers, decreased vaginal depth, and pale dry vagina with friable epithelium, which lacks normal mucosal erugii. On laboratory testing, the vaginal pH in atrophic vaginitis is more than 5 and can be measured by pH indicator, a strip inserted into the proximal 1/3 of vagina, and lower level of circulating estrogen, that is less than 25 picogram per milliliter, will be there. And if we do microscopy, a wet mount, we can find out a candidiasis or trichomoniasis or vaginitis due to bacterial vaginosis, or we can exclude it. So it can complicate it and make it bacterial or fungal vaginal infection, and it can also cause cracks in the vaginal wall. It can cause dyspareunia and bleeding after intercourse. So friends, now let's see how to manage it. Hormone replacement therapy, which is called menopausal hormone replacement therapy, MHT, menopausal hormone therapy rather. This is in the form of tablets or patches or cream, is used to replace the estrogen that ovaries no longer make during and after menopause. Hormone therapy may have either estrogen alone or estrogen plus progesterone or androgens or tibolons also. Generally, the use of HRT for a short period of 3 to 5 years have been advised. And reduction of doses should be done as soon as possible, because previously it was thought that it should be taken for a long period, but now it is given for a short period and it is individualized. The treatment is individualized for each patient. There is no one size fit all, and so it has to be for a short period in the minimum doses. So the indication is to relief of menopausal symptoms and prevention of osteoporosis, to maintain the quality of life in menopausal years, And the special group of women to whom HRT should be prescribed are those with premature ovarian failure, gonadal dysgenesis, and surgical or radiation menopause. Because in surgical menopause, there is sudden loss of estrogen if bilateral oophorectomy has been done. But in premature ovarian failure, there is gradual loss, so that the symptoms don't come so suddenly. But in surgical menopause, the symptoms come very suddenly. So if you still have your uterus, patient didn't have hysterectomy, then there is a need for treatment. Then it combines the estrogen and progesterone sequential. And second, estrogen alone is suitable for women who have had a hysterectomy. In them, estrogen alone can be given. And vaginal estrogen therapy is useful for women who have local symptoms such as vaginal dryness. Previously, there were only tablets for that, but now we have creams, we have patches, and other modes also. So, risks of hormone therapy: this is endometrial cancer, venous thromboembolic disease. It is increased risk within 1 to 2 years after initiation of hormone therapy, and breast cancer, increased breast density with progesterone via proliferation of estrogen dependent mammary tissue, and making it more difficult to detect breast cancer early with a mammogram. Previously, it was thought that estrogen increases the incidence, but now it has been found that it is not such, and progesterone also does not increase the incidence as such. Ovarian cancer, if it is given more than 10 years estrogen therapy, then there are chances of increased risk of ovarian cancer. Cerebrovascular accidents and lipid metabolism is derailed, so an increased incidence of gallbladder disease has been observed following hormone replacement therapy due to rise in cholesterol. So the commonly used estrogen are conjugated estrogen, but nowadays there are other preparations also in the doses of 6.625 milligram to 1.25 milligram per day. But after a while, it is made half. That is 3.3 milligram is used. Progestin used are medroxyprogesterone acetate in the doses of 100 to 300 milligrams per day. And considering the risk, hormonal therapy should be used with the lowest effective dose and for a short period of time. Low dose of oral conjugated estrogen is 0.3 milligram per day daily is effective and has got the minimal side effects. Coming to progesterone, patients with history of breast carcinoma or endometrial carcinoma, then progesterone may be used. It may be effective in suppressing hot flashes, and it prevents osteoporosis also. It is medroxyprogesterone acetate is given in the doses of 2.5 to 5 milligram can be used. Then comes tibolone. Tibolone is a steroid having a weakly estrogenic, progestogenic, and androgenic. It has all the three properties. So it prevents osteoporosis, atrophic changes of vagina, hot flashes. It also increases the libido. A dose of 2.5 milligram per day is given. Curative. Is non-hormonal. For curative, this is non-hormonal first-line therapy for women for vaginal atrophy includes non-hormonal water-soluble vaginal lubricants and moisturizers. Women should also be encouraged to continue sexual activity. In hormonal therapy, there is bioidentical vaginal preparations are more effective than oral or transdermal preparations in causing relief in manifestations of atrophic vaginitis. Bioidentical vaginal estrogen require lower doses than systemic therapy, and it is the treatment of choice for such women. Bioidentical vaginal estrogen therapy is available in many forms: creams, tablets, suppository, or rings. And the best selection is the form that best suits an individual patient. So it is just individualized treatment and not one size fits all or one thing fits all. Soya phytoestrogen, black cohosh also have been shown by Cochrane's study to have a good effect. So increased interest in soya isoflavones, which is a weaker estrogen supplement over the years has been seen. No conclusive evidence of improvement in menopausal symptoms has been seen in 43 randomized trials. A meta-analysis of black cohosh reported insufficient evidence to support the use of black cohosh for menopausal symptoms. Thus, isoflavones are not a suitable alternative to hormone therapy. That has been seen. Even in this study, it is a randomized double-blind trial. This also shows that isoflavones, 2 years even after 2 years of age, has insignificant results. So, what is the ideal menopause solution? Ideal menopause solution is that it should regulate endogenous estrogen to non-productive organs and reproductive organs, and it should offer symptom relief as good as hormone therapy, but without the risk of cancer, venous thromboembolism, and stroke, which may be associated with hormone therapy. So there are few medical herbs which the following active ingredients which has shown promising results, and this may be a little bit new to us, but it has been shown that cinnamic acid, that is in Cynachum wilfordi, and S-methyl ester, that is in Phlomus umbrosa, and Angelica gigas, that is in D-curcinol angelate. These are the things, and in which these are the active symptoms, active ingredients which help in menopause and acts as menopausal hormone therapy. So, cinnamic acid, it is a natural remedy used for hundreds of years in both Korea and China, and it has shown significant improvements in the quality of life for women dealing with the symptoms of pre, peri, and post-menopause. Angelica gigas, this is ultra-fine Angelica gigas powder, which normalizes ovarian hormone level and has anti-osteoporotic properties in ovarectomized rats. Herbal formulation composed of a combination of all three, that is Cynachum wilfordis, Hemsley, Phlomis umbrosa, Turk zaninovo, and Angelica gigas nakai. And extracts, that is called CPA, have been used for treating menopausal symptoms in Korea and China. So there is some clinical evidence which says the efficacy and safety of nutraceuticals on menopausal symptoms in postmenopausal women has been shown in randomized double-blind placebo-controlled clinical trials, which shows that a combination of alternative supplementation may improve menopausal symptom in postmenopausal women. This is the study. And there are a few more studies which has shown the effect of the aqueous extracts in the rat models on postmenopausal hot flushes, and also on the women. The other studies, this is evaluation of estrogenic activity of extract from the herbal mixture, and that has been tried on the women. So, but the basic thing is lifestyle management. The solution remains in lifestyle management rather than more of the drugs. Let's see. So, the lifestyle management, physical activity is the thing which can improve the menopausal period. Targeted exercise, such as balancing exercises, such as concentration exercises, weightlifting, all these have a very good effect on the women and their physical as well as mental well-being. Nutrition has a great role. Don't neglect yourself even after you have, after your menopause, because you need more of the good nutrition and good micro nutrients and macro nutrients for your well-being, including protein also. Avoid alcohol and tobacco, that is always there. Stress reducing strategies is a must. Because stress is a very big factor which can derange all your life. So meditation, paced respiration, all these should be practiced. Massages is very important, and hobbies. You must have a hobby so that it will engage you, as well as it will also improve your cognitive function, reduce, it will stop declining your mental functions. And nutrition, as I said. Emotional stability is also a must, because of the moodiness, estrogen, lack of estrogen, all these affect this emotional stability. Positive attitude, again, this is very important, because unless you have a positive attitude, you will feel life worthless, and then you will go in depression and all the bad things of it, all the bad thing of negative attitude. Family involvement, this is the best part, to use your time very in a very good way. Family involvement should be done, and there you should always be there to support the family and improve your value. And spiritual attitude again helps a lot. Sleep is a must. Though there is a lack of sleep, you feel lack of sleep, but you don't feel you feel insomnia, but still 8 hours sleep is a must to keep you healthy and keep your brain from agile. Now, for living with menopause, you have balanced nutrition and diet. So the base of this pyramid comprises of cereals and millets, which should be 270 grams daily. Vegetables comes next. Vegetables and fruits comes next. All the leafy green vegetables and multicolored, and all the fruits which is multicolored. 300 grams vegetable and 100 grams of fruit. Then comes pulse, milk and milk products. That's again 300 grams. And pulses with non-veg. So pulses 60 grams and non-veg 30 grams daily. Then comes fats and oils, only 20 grams. And sugar, again 20 grams. So this is the balanced diet for adult women who has reached postmenopausal age or menopausal age. Sugar, 6 teaspoonful per day. That's also very much, I think. Salt, 1.5 teaspoonful or 3 to 5 grams per day. Oil, 2 tablespoons per day. Fruits, 100 grams per day. Vegetables, 300 grams per day. And drink 8 glasses of water every day. Please keep yourself hydrated. Hydration is very, very important for your skin as well as for your gut and for your whole body system. Add powdered flaxseed, cinnamon, fenugreek, sauce in salads and curds. These will provide all the micronutrients to you. Avoid more than 200 milligrams per day of caffeine. Limit intake of tea and coffee to 3 cups a day. 1 cup, that is 150 milliliter of brewed coffee, is equal to 120 milligrams of caffeine. So must take note of it. 65 milligrams for 1 cup of instant coffee, 65 milligrams of caffeine for 1 cup of instant coffee and tea. Consume a minimum of 500 to 600 milliliter of milk or curd, that's of low fat, to build on calcium bank in the bones. Calcium is a must, and support it with lots of vitamin C rich fruits, vegetables, to favor calcium absorption as well as vitamin D. So nutrition is very important in menopausal age, and the recommended dietary allowance for calcium and vitamin D is calcium is more than 100 milligram per day to 1,200 milligram per day. Upper limit of normal is 2,500 milligram per day. Vitamin D 1,500 to 2,000 unit. Upper limit of normal is 10,000 unit per day. But actually, there was a person who did research on vitamin D, and he recommended that vitamin D 60,000 unit, if you keep it fortnightly, it will never let your vitamin D level be down, and it will it will never cause hypervitaminosis. So, but you can use this also. Thyroid medications, corticosteroids, tetracyclines, and anticonvulsants, and calcium should be taken separately. Don't take all the medicines in one gulp. Calcium is contraindicated in patients with hypercalcemia and with renal insufficiency and with caution in nephrolithiasis. Excess amount, that's more than 2,500 milligram a day, it affects kidney and can reduce the absorption of other minerals like iron, zinc, and magnesium. Cholecalciferol, that is vitamin D3 tablets or powder, 6,000 IU once a week for 8 weeks, preferably with milk, or once IM injection of 6 lakhs is given to correct the deficiency. but should not be repeated before 3 months and may be given after confirmation of persisting low levels of vitamin D. And maintenance therapy from natural sources or supplements is advised after correction of the deficiency. So, to conclude, friends, women live 1/3 of their lives in postmenopausal period. Perimenopausal and postmenopausal women may be affected by symptoms and conditions associated with hypoestrogenism like vasomotor symptoms, vaginal dryness, osteoporosis, and also UTI. Most women, hot flashes usually resolves without treatment. But women may ask treatment for it if it bothers her very much. As HRT have its severe drawbacks, non-hormonal management is the best choice. It is the first choice of treatment in menopausal issues. Complementary and alternative medicine is an efficacious treatment strategy. Eating the right diet along with supplements, having adequate sleep, and exercising regularly can lead a blissful postmenopausal life. Thank you. Thank you so much for your patient listening.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. Yes, ma'am. As you were saying that each postmenopausal woman has to be tailored and specialized, individualized treatment has to be given for any postmenopausal woman. Thank you, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I'll read it for you, ma'am.
Sure.
Ma'am, I personally have a few questions, ma'am. Like whether the postmenopausal woman with thyroid dysfunction increases the risk of osteoporosis, ma'am.
Yes, it does. So you have to maintain, you have to give, since the BMI is decreased in this period. So the thyroid treatment, I mean, you have to step up the thyroid medication.
Okay, ma'am. Ma'am, in your presentation, you were saying that you have to stop this HRT with a period of 3 to 5 years, ma'am. So, and we have to gradually reduce the ART treatment, ma'am. So, what is the case in case of this operative, hysterectomy, something like that, ma'am? So, in that case, how long they have to take treatment and what is the treatment protocol?
Oh, very good question. Actually, I wanted to address this. Actually, there was a WHI study. Previously, what happened that almost 45% to 50% women in USA were prescribed HRT regularly without any, I mean, single drop of thing, they were being prescribed, and it was a huge industry. Then came the WHI study, and that WHI study made a U-turn of the things. And after that, because the results of the study were published, prematurely and without proper analysis, and so it concluded that the study was also stopped in between. It concluded, gave the impression that HRT is very bad. It should not be prescribed. It increases the cardiovascular risk. It increases the breast cancer risk. It increases the endometrial cancer risk. So that was the WHI study and the statement which it gave prematurely. So what happened that abruptly the whole hormone replacement therapy was stopped, and people started fearing. Later on, when the same data was analyzed again after, people kept analyzing it, that why it is so. Then it was found that this study was, first of all, a preventive study. It was the largest study in the world of postmenopausal women with HRT, but it was a preventive study to know whether it can prevent the cardiovascular risks. But this was not the case. The message now as it comes that menopause, that this is not a preventive thing. You cannot use it for primary prevention of cardiovascular risks, chronic coronary heart disease, and things like that. But in all ages, at all periods, it has a beneficial effect on osteoporosis in every stage of life: perimenopause, menopause, late menopause, everything. But it has been found that after, suppose, surgical menopause, so how long should you give? So the thing is that it has been found that from surgical menopause, if the woman is experiencing uh, uh, symptoms, then you should treat her, and this treatment should continue till the age of natural menopause. Got it? And the second thing which has come into picture is that if you prescribe MHT, best acts when it is prescribed within 10 years of menopause. Suppose the menopause has occurred at 46, then if you start it within 10 years. Don't start after 10 years, because if it is started after 10 years, then its risks are more than benefit. So if it is started in more than 60 years, more than 70 years, you should not start. If it is woman is between 40 to 50, always benefit is more than the risk. In approximately at 60 years age, you have to balance both, whether risk is more or benefit is more, because it has to be individualized. But between 50 and 60, you can prescribe, because the risks are less than and benefit is always more. So this has been found by even Indian Menopause Society recommends it.
So, ma'am, I can take like this, in this way, ma'am, whether if you are prescribing HRD, we can give another drug like our estrogen in a combined manner, so that we can withdraw slowly, ma'am.
Yeah, estrogen syrup, it is not a hormone, really. It is not a hormone.
Yes,
it acts like a hormone. So you can start that. I also in the presentation also does that non-hormonal treatment you can start first, if they, because these are mild things.
yes,
And if it acts and women is relieved, then there's no use to go to hormonal part. So, but if it doesn't act, suppose she is still having problem, then you have to move to HRT. And later, when you can't give HRT, in that phase also, if they need they are having some menopausal symptoms, and you cannot prescribe HRT, then you can again go to these things. But in the case of osteoporosis, you can prescribe estrogens in the case for osteoporosis even later, after 60 also, but in the small doses and for a limited period again. It is not to be continued lifelong.
Okay. Ma'am, what will be the beneficial effect of this probiotics and prebiotics in postmenopausal women, ma'am? So whether you recommend these probiotics, in particularly when it comes to any infections or any other indications, how you recommend these probiotics, ma'am?
Yes, I do recommend, because of the vaginal epithelium has got thinned out, so there's more chances of vaginitis, and there are more chances of secondary infections also. And these probiotics and prebiotics, they act really well in the vagina as well as in the urethra also. So I really do recommend women prebiotics and probiotics at this stage. even when I withdraw the hormone therapy, I suppose local estrogen I have given, and then I gradually, when I withdraw it, I put them for 1 month or 2 months on the prebiotic probiotics, so that they can feel better, and if at all they can again switch over or come back to me.
So, ma'am, we have one question, ma'am. What should be the ideal treatment for treating this vaginal atrophy, ma'am? Whether any surgical procedure or any laser treatment required, ma'am?
Well, I'm not a cosmetic surgeon, but these days this laser treatment has become something very important. So for that, I would really say that one should go to the cosmetology person. They can, I would say, better. But vaginal, if she is below 50, suppose, if she is below 50, and then you can very well use Tibolon. Tibolon is very good for that. Even up till 55 or even up to 60, you can use it, Tibolon, and that helps in the atrophy and all that, real, because it has testosterone like property also. So, but after that you can't use it, and you have to be careful about your breasts at that time while using Tibolon, and going for mammograms and clinical breast examination. These are the must, as well as pap smear and all. So you can, this is for cosmetology, I would really refer them to a cosmetic person, not me.
We have another question, ma'am. Whether this ADHD, attention deficient hyperactive disorder, women who are going through menopause experience an increased ADHD symptoms.
That ADHD is, it starts from early childhood also, and all those transition phase it might be. I think meditation and spiritual things can help them for there, or else you can try with herbs which have isoflavones and all those properties, like your estrogen and all. You can try, but it will more help these people in by meditation and emotional support rather.
Yeah. So, ma'am, we have one last question, ma'am. Whether this acupuncture treatment or any reflexology really works in this postmenopausal woman, ma'am?
For what?
Or
I mean,
all
for
these
what?
postmenopausal symptoms, ma'am? Like
Again,
hot flush.
I will say that I am not a proper person to answer these questions, because I have never experienced it, and nor I have any feedback from my patients. So it's better to have a person who is concerned.
Yes, ma'am. Fine, ma'am. I don't find any other questions in the chat box, ma'am. So if you
Okay.
allow us, then we can end the